good stuff. So we'll make a start then. So as I say, my name is Matt Williams. I'm the clinical lead MSK podiatrist in the South. I'm based at Park House. But I'm going to give you a bit of information about the service today and what we do, and a little bit of CPD about forefoot pain as well as we go through. So I'm sure it's all a refresher, because I was saying to Desi, you guys generally your referrals are really good, and I know you know plenty about feet already, but we'll just do a little refresher as we go. So introductions and names, let you know about us and what we do and where we're based. So we're based right across the county. So I'm based at Park House, but we've got clinics across the city, Mid-Notts and up into Bassetlaw. An overview of MSK Podiatry, and as I say, a little bit of a CPD around forefoot pain. So a bit of a meet the team. So I'm based in the South. We've got Richard Marchant, who's the clinical MSK lead in Mid-Notts, and Adam Jordan, who's the clinical lead based at Mary Potter in the city. I did ask them to both send me a photograph of them so I could upload it onto here, but they both very shyly declined. So they've got what I've given them there. It could have been a lot worse. So what do? We provide kind of foot and ankle assessments at 6 locations across the county, 3 clinical leads, but we've also got 5 specialist MSK podiatrists as well, who are generally on a kind of part-time 1 or 2 days a week. We provide various forms of orthotics, local guided steroid injections, footwear advice, rehab. So, good crossover between what you guys do and what we do as well. And timely referral onto other service, mainly kind of surgery generally. How you can access us, as you all know, we're on F12. You can email the referral directly to us at the spa, or paper referrals to the spa. And patients can now self-referral, and that's a kind of increasing kind of number of referrals we're getting are patient self-referrals. So if you have any concerns at all, email addresses are there. Just get in contact with us, or you can task us on System 1 for those on System 1. So phone, email, task anytime you like. So you'll all be familiar with this. This is our referral form. It is really wordy, and we're very aware of that. And that's because it's kind of covering MSK podiatry, but also core podiatry, high-risk podiatry, nail surgery, and podiatric surgery. So to try and get that all into one succinct document is quite difficult. But kind of just include as much information on the referral as you can. We've got those boxes on the right-hand side if you have a look. So providing it's not nail surgery or core podiatry or urgent core podiatry, don't worry too much about which of those boxes you tick, because we're going to do a triage anyway. So if you're a little unsure of which of the boxes to tick, don't worry too much. But obviously, the more information at this point you can give us, the better in terms of our triage process, because they may be directly triaged to surgery in some cases. So copy and pasting from your notes is fine, but as much information as you can possibly give us, that really helps with the triage. Any photos you can attach are really helpful. For those on System 1, you don't necessarily need to attach them. If you just tell us that they're on System 1, that's really helpful. Any previous imaging that they might have had, again, we can access that on MRAD. So if you can just kind of make us aware of that, it all helps with that triage process and directing patients to kind of where they really need to go. If we focus just a little bit on the kind of MSK and podiatric surgery side of things, in terms of our access criteria, it's pretty broad, to be honest. So any foot or ankle MSK pain that's been unsuccessfully treated in sort of first contact. When you are making those referrals, say if you could consider some imaging at the same time, that'd be really helpful for soft tissue problems, ultrasound, bony or joint problems, X-ray. That's really, really helpful, because that kind of speeds up the process for patients if they've already got that in place when they come and see us. We do have a bit of a discrepancy across the county that in Mid-Notts and Bassetlaw we are able to refer for imaging, but in the south around NUH we aren't. Hopefully that's going to be sorted out really soon, but if you guys could help with that imaging, that'd be really helpful. The only thing that's not on there is that we don't accept referrals for patients under 5, so children under 5 aren't accepted in community podiatry. Moving on to podiatry surgery. So again, it's kind of anything that's kind of not resolving with non-operative management, but it is day case, local anaesthetic surgery, podiatry surgery unit. So they cannot be offered general anaesthetic. So generally speaking, they've got to be sort of systemically well, you know, nothing that's kind of unstable in terms of their physical or mental health. Severe anxiety is a big one. You know, if they aren't going to be able to kind of cope with that process of having it done under a local, then they're probably best off referred straight to orthopedics. As I say, we cannot offer that kind of general anaesthesia or any heavy sedation. The only things, as I say, that we perhaps have changed recently is we no longer accept referrals for conditions that are kind of originating above the ankle. So in the past, we may have got involved with, you know, medial or anterior knee pain, patellofemoral syndrome, radiculopathies. Unfortunately, with kind of limited resources, we've had to kind of limit our resources to where we're kind of most effective, which is kind of foot and ankle conditions. So what will happen when we receive the referral? Well, the triaged. So, you know, say taking that information that you've given us, we usually request photos at that point, and we can have a look at previous imaging on MRAD, and we also use a podiatry triage questionnaire. This is come from something called the MOX-FQ. I don't know if anybody would be familiar with that. It's a podiatry audit tool that we usually use pre and post operative or pre and post injection, and it's a sort of quality of life outcome measure really, but it provides a score at the end, and the intention is that we'll use that score to determine in the future which patients we see or where they will kind of get triaged to. At the moment, it's a bit of a pilot, but it seems to be working quite well, and we might roll it out a little bit more as time goes on. I mentioned about kind of the sort of rejected referrals. Most often they're rejected simply because we don't think we're the kind of best people to see them. So they might be passed on to surgery or pain management. Maybe if we've seen that patient before and tried intervention and it hasn't really worked, or orthotists. Sometimes we get a lot of referrals for bespoke footwear, which is not something we provide in podiatry. So we just pass those straight on to secondary care orthotists. When they are accepted, as I say, they can be seen in our core podiatry team, so not necessarily an MSK specialist, particularly if it's a common condition with sort of little previous intervention, bearing in mind those kind of self-referrals. Anything more complex comes straight into MSK, either the specialist or the clinical lead. So commonly, what are we seeing? You'll be familiar with all of these common foot conditions, soft tissue pathologies, tendinopathy, fasciopathy, which I know you've kind of covered before. First ray disorders, so there's kind of big toe joint problems, hallux valgus, OA and sesamoid problems. Deformities, so that's both of the toes, but also kind of the foot itself, you know, significant flat foot, PTTD, problematic cavus foot, and degenerative joint disease, which again, I'm sure you're kind of all familiar with. What we're going to focus on today is metatarsalgia, that kind of ball of the foot pain. I thought it might be a good idea to give you just a little refresher on that, because certainly within the kind of podiatry sphere, it's an area of the foot that sometimes people get a little bit confused about. There are a lot of very similar conditions with similar histories, and sometimes they can be quite easily mixed up. So I thought we'd just look at that in a little bit more detail. So metatarsalgia, or pain in the ball of the foot, really common symptom. A lot of kind of differential diagnoses for pain in that area. And what I thought we'd do as a bit of an interactive thing is if people wanted to kind of shout out some common pathologies that they would sort of put under the umbrella term of metatarsalgia, and we'll see how many we've got that are similar to my list.
Morton's Neuroma. Morton's Neuroma.
Excellent. Yes. Really high on the list, that one. Yes. Write in the chat if you don't want to shout out.
Plate injury.
Excellent. Yes. Really good. Yeah.
Bursitis.
Excellent. Yes. Hitting all the top markers, definitely. Okay. I'll put the list up. So sort of roughly in a list of sort of commonality, really. We mentioned a few of those real top ones. So capsulitis, synovitis, and I would include plantar plate injury in that, and we'll discuss that in a little bit more detail. Neuromas we mentioned, and probably the other most common one is a Freiberg's or OA. We'll kind of lump those together. Some much rarer ones and some much more significant ones, but thankfully, you know, we don't see these so often. So subluxation through both trauma, but also mechanical. Transfer metatarsal, a lot of these kind of ball of the foot pains generally originate from some kind of first ray insufficiency. So either a bunion or arthritis of the big toe that's causing that shift in weight from the first ray onto that second ray. Again, many of our self-referrals, they come in as MSK referrals, but really they're dermatological problems. So corns, calluses, and what we refer to as IPKs, intractable plantar keratoma, which is a very posh way of saying corn. And certainly they use that in the kind of surgical sphere. Intermetatarsal bursitis and plantar metatarsal head bursitis we mentioned, gout, pseudogouts, infections, fractures, RA, or other inflammatory conditions, and tumours, etc. These are much rarer, of course. So if we focus on that kind of swollen, painful joint to begin with, the really common forefoot symptom, usually associated with functional or structural abnormality or traumatic injury. So I would definitely say many more of these are a kind of slow burning structural abnormality than they are a kind of acute injury. It's not so common that people will say I kicked the bedpost or I dropped something on it or something like that. It is much more of a kind of functional problem. Multiple differential diagnoses, as we've discussed, and multiple contributing factors. So this can really be quite subtle in the early stages. I've put some photographs up there. I think you can be forgiven for looking at both of those images and thinking there's not a huge amount going on there. If we look at the top image, pretty much the toes are fairly rectus, fairly straight. Subtly, we can see a few little changes, and I'll just highlight them for you. So at the base of that second toe, we can see a minor amount of swelling. That's a bit of a trigger, and the best way to tell this is by getting the other shoe and sock off and comparing them. And usually you can see a little bit of swelling at the base of that toe. The giveaway sign is that little bit of creasing in the toe crease area. You can see the sort of creasing of the skin. Subtly again, we can see the second toe is significantly longer than the first toe, or we generally describe this as a short first ray, and that is a bit of a mechanical weakness, and a really common feature you see of second MTP joint swelling, capsulitis. We think about what the patient says to us. So history is key, really. They tend to describe feeling of a walking on a stone, walking on a marble. You know, they're aware of a feeling underneath their foot that's painful, and it's definitely activity related. But the thing that's going to concern us the most is the movement of that toe. And you can see on the bottom picture there, we've got elevation of that digit. So it's not hammered. There's no kind of lesion on the sort of proximal IP joint like you can get with a hammer toe, but it is elevated out of alignment with toes 1 and 3. You can see it's kind of floating. It's got no purchase, no ground contact, and we can also see that it's slightly sort of moving towards the first toe. So some subtle signs of kind of instability around that second MTP joint. You can also see it's slightly rotated, so you can see the nail is slightly pointing towards the fifth toe, which again is a feature you often see. Just to sort of touch on terminology, we tend to call this capsulitis in podiatry, but I'm aware that in other professions it's known by lots of other names, and certainly in the literature it's known by a lot of other names. I think we're sort of moving more towards pre-dislocation syndrome, and I quite like that term because I think it reminds you what happens if we don't treat this effectively, and effectively this is what's going to happen. We're leading to kind of quite significant deformity of the forefoot if we don't manage that problem quite well. So here we have a significant plantar plate injury or disruption, as we talked about, now leading to kind of a significant hammer toe deformity and a crossover toe. So it's really going over that first toe. So things that patients might say to you, they might say, I did have a pain underneath the foot, but now that's gone. So often the pain has really settled down, but their biggest issue now becomes footwear They're really struggling to get any shoes on at all, even very sensible shoes. So these are the patients that walk into your clinic in winter in a pair of slippers or sliders because they can't get anything on. Sometimes they'll see a bit of callus underneath the second MTP joint. That's really common as that mat head sort of plantar flexors. So in terms of your exam, again, I know this is a refresher, you're probably all doing this, but direct palpation of that second metatarsal head is going to be really uncomfortable for these patients. Mobilizing that joint, particularly in a kind of plantar flexion, is going to be really painful for these patients. We tend to think about the kind of laxity of the joint and how likely it is to end up in those severe deformities. So we'd use the drawer test, which you'd obviously use for other joints as well, to have a look at that laxity. It can be quite difficult with toes, they're quite fiddly, but really stabilizing the forefoot with one hand and kind of trying to get that vertical displacement with the other hand. And it can be quite noticeable. And again, if you can compare it to the other toe on the other foot, that's really helpful. I would just utter a word of caution about doing that in a very inflamed joint. Obviously, you've got a risk of kind of expediting that deformity if you aggravate that joint too much. So we talked a little bit about why it happened and some of the mechanical factors, but as well as the kind of transfer metatarsalgia, that passing of the main weight bearing pressure from the first ray to the second, we've also got a bit of something going on with the stabilizer. So the dynamic stabilizers of the foot, the interossei and the lumbricals in the arch, and the kind of flexors and extensors coming down the leg and inserting into the toes, versus the static stabilizers, those collateral ligaments around the joint and the plantar plate. And eventually those dynamic stabilizers are going to win that battle. So this is that general kind of pathology and progression from inflammation through to attenuation, rupture of the plantar plate, and eventually instability and deformity. So what we're going to do about it, early intervention really can be very successful as long as we're quite quick. Sadly, we don't always see these patients before they end up at that deformity, but when we do, it can be really effective. So it's really a question of kind of trying to immobilize that joint as much as we can, but still allowing the patient to function as much as normality as we can. So one option would be a controlled ankle motion boot, an air cast or something. But I tend to find that patients are a little reluctant to go to that because they've often been coping quite well up until that point. So they don't always want to kind of take that step towards something that seems quite interventionist. So we try and do it in a kind of more subtle way. So certainly ice packs are really helpful for getting that swelling down. Structured running trainer, offloading orthoses, and I've put a couple of examples of some orthoses on here that you can direct patients to buy. These are kind of well, like everything in life, they're available on Amazon, but other kind of online stockists as well. And what we're looking for from the orthotics is some kind of offload for that central forefoot area. So these ones have got a metatarsal dome pad already included in the device. So often orthotics require kind of modifying, but these ones, are quite good because they're already kind of got that included. We've got a hand up there, Des, here.
Yeah, so just to recap, what would you expect from primary care clinicians before they come to you versus, so we don't have access to things like boots. When would you think it's time for you? So
definitely if you've given that advice about footwear and certainly the orthotics, I think that's something you could definitely advise. And sometimes I think people can be a little bit afraid of advising orthotics in case you get your wrong thing, but as you're going to see as we progress through, this particular style of orthotics is useful for any central forefoot pain, and because they don't need any modification, they're easily and fairly cheaply purchasable. I think that's a reasonable thing that you could try. I sent to you earlier, Desi, a document with orthotics for sort of common foot conditions, so you could kind of refer to that document if you're unsure.
Emailed out afterwards to everyone.
Yeah, that's great. So I think that
just
would definitely
one more.
Yes, go for it. Yeah.
What else would go on the referral? So what would you want for us to have done in primary care, be it what we've tried, any imaging or any certain pictures in this case?
Yeah, so if you are able to ask the patient to send some pictures to you, or if you take pictures and upload them, that would be really, really helpful. So in terms of pictures more generally, we're on system 1. So if you've uploaded system 1 pictures, you can just tell them about us. If you're using other systems, you might have to kind of obviously include them in the referral. In terms of kind of what views, generally speaking, we similar to what you might get for like a weight-bearing X-ray. So if you've got a view, a sort of DP view looking down on the weight-bearing foot and maybe a lateral, and then sometimes if you sort of mark or point to the painful area on the foot, that is obviously quite helpful. But I'm sure you all know you get what you get with photos, don't you? It's not always that easy, but they're quite easy because then we can have a look at kind of any deformity really. But one of the main things that you guys could do in primary care is strapping. I mean, I don't know if this is something you would commonly do, but this strapping is really helpful at kind of immobilizing that toe, but still allowing the patient to kind of move around quite well in a reasonable shoe. So it's this kind of simple loop strap at the base of the toe, and then just crossed over underneath, and they can keep that on for a day or two, or change it every day if they prefer. And patients are usually quite good at doing this themselves, and usually get on with it quite well, I find. And if we can do that for sort of 4 to 6 weeks and really immobilize that toe, we've got a reasonable chance that some healing can take place in that plantar plate, and we might prevent that kind of further deformity. But if we don't, sadly, we're coming to more invasive things. So historically, steroid injections were used quite a lot for lesser MTP joint pain, but we're now a little bit more aware of kind of the weakening around the kind of those static stabilizers that we talked about, and the risk of them becoming weaker and expediting sort of quicker deformity. So really, if I was going to do a steroid injection for that, I'd want it to be guided, and I'd really heavily counsel the patient about resting afterwards for a good couple of weeks, no heavy weight bearing or high impact activities. But there's a big caution around injections for this one. So many more of these patients probably go to surgery a little earlier than they would have done. Previously, we probably would have waited for the deformity to get quite bad, and then kind of the surgery would be about kind of reducing that deformity. But they have some other options now. So I mentioned about a lot of these cases have a kind of long second metatarsal bone, and that's quite a predisposing factor. So commonly a wire osteotomy would be used to kind of shorten that metatarsal bone, and that can be really helpful at bringing the toes back into a better alignment. But much more commonly now, they use what's called a Viper system. I'm not a surgeon, so I can't describe exactly how they do it, but essentially it's kind of repairing that plantar plate through some very specific suturing techniques, and it can be really successful at preventing that deformity. So more of our patients go much earlier to surgery as a result of this system than ever did before. Okay, so moving on to probably next most common on our list, and was shouted out by somebody, is a neuroma. So we tend to think of them all as Morton's neuromas, but Morton's neuroma is classically that kind of third intermetatarsal space, thickened inflamed nerve tissue. Again, many possible causes. So again, if we go back to the history, subtly there's some differences with what patients might say to you with a neuroma against a joint problem. So they usually have a kind of burning sensation in the ball of the foot, but they usually have some sensations and pain in the toes as well. In fact, very commonly patients will say, my toes hurt me, there's something wrong with the nail, and you look and you think there's absolutely nothing wrong with your nail, and it immediately raises suspicion to me that there's perhaps something going on a little bit further back than that. So they also may describe to you a clicking sensation when they walk around. The pain is often quite short-lived, so it'll be when they're walking around, they'll get the pain, they take the shoe off, maybe give it a bit of a rub, and the pain goes away. And again, with capsulitis, that pain tends to sort of drag on for a little longer. Classically, we think of kind of court shoes, cycling shoes, very narrow shoes, but I think you get a lot of patients with quite a broad foot, which even in fairly sensible shoes may still get this as a problem for them. So as I say, the history there, toes feel painful, numb and tingling, goes off when I take my shoe off. That is the kind of absolute classic symptom. Most common in women aged 30 to 60, but certainly not exclusively, often seen with a flexible flat foot. and pain on compression, so a sort of squeeze across the met heads may reproduce that pain. We tend to think of doing the Mulder's click test, which again I'm sure you're all familiar with. It's quite a difficult maneuver to do actually, really, particularly if it's not in the third space. The third space is easier to do. It's a sort of slightly broader space between the met heads and the second and third. As much as you possibly can, you're trying to kind of align those metatarsal heads, and then give it a good squeeze, either kind of across the whole foot or more focally to the met heads you're dealing with. But it is quite difficult. I tend to think of it more of a Mulder's clunk than a click. It has a very characteristic kind of clunking noise. You can feel it, you can often hear it, the patient feels it, and it should reproduce symptoms. If you get a bit of a click but they don't get any symptoms, I'd have a little caution about whether the neuroma is causing them the problem. Even if there is one there, it should reproduce those symptoms. Again, a little caution about gapping in the toes, sometimes known as daylight sign. That's much more common with joint problems than it is with a kind of space occupying lesion between the met heads. Caution around if it's not in that third space and if you can't reproduce the click. So if you've got a patient who fits all the classic symptoms and you've got a Mulder's click, I wouldn't necessarily advise any further investigation. I think we'd be happy to take that diagnosis on a clinical diagnosis. But if there's any queries, obviously ultrasound or X-ray if you suspect any bone or joint abnormality. In terms of treatment, so I mentioned we can use these same insoles for lots of kind of central forefoot problems. Wider fit shoes is the biggest key, probably, over insoles in these cases. But you know, being honest, there's a big failure rate with kind of non-operative treatment for neuromas. I would say probably around less than 50% improve with changing their shoes and using insoles. So often these patients are going on to kind of more invasive treatment. We would usually try 2 or 3 injections, local steroid injections, for these before we would consider surgery. But if the patient kind of declines those, or they get adverse effects, or they're not effective, then they do end up with neurectomy. There are 1 or 2 other options that you might hear patients kind of having read up on: alcohol ablation and cryotherapy. They're kind of newer, lesser performed treatments for neuromas, and we don't offer them in Nottinghamshire. They're just in small pockets around the country, really. So as I say, many of these patients will end up in surgery for neurectomy with release of the deep transverse metatarsal ligament. Pretty good outcomes in most cases. Recurrence in about up to 15%. CRPS in 1 in 1,000, pretty low. They will almost certainly end up with loss or altered sensation in the affected 2 toes. So, you know, again, you could mention that to patients if you're referring them on to surgery, that could potentially be kind of one of the outcomes. Recovery for this is about 4 weeks, and then the patient's usually back to pretty much normal function. So the final one of the 3 I thought we'd cover, Freiberg's, which is an osteochondrosis of the metatarsal head, leading to flattening and collapse of the head and eventual kind of frank arthrosis. So similar symptoms. So we've got joint pain, very similar symptoms, but there are, again, some subtle differences. So they will have very focal pain in that metatarsal head. They'll again may describe feeling of walking on a stone, but the kind of the sort of type of patient will vary a little bit. So, you know, this begins in adolescence, so around 11 to 17, again, more common in females. Second metatarsal affected, roughly 2/3 to 1/3 with the third metatarsal. Different to synovitis, capsulitis, this time you will get stiffness in that joint. Even in early stages, it will usually feel quite stiff. You'll have crepitus, kind of all the normal features of an arthritic joint, really, which is effectively what's going to happen to that joint. I would say we very rarely see adolescents with this problem. We usually see the kind of later onset outcomes as a result of it, really, that kind of arthritis in the joint. In terms of imaging, early on, it can be quite subtle again, but you can see some changes kind of early on with Freiberg. So you've got that flattening of the metatarsal head, an increase in joint space, and subchondral sclerosis. And then in much later stages, you can see, really quite frank arthrosis, heavy osteophytosis, a joint that's pretty stiff and pretty immobile. In terms of what you guys can do, so again, it's quite similar. So reducing if you do see those kind of adolescent patients, reducing their activities at that point, really helpful. You mentioned you don't have access to like a walker boot, but maybe you could refer to us for that if that was the case. Or you could just try a very cushioned shoe or a walking boot to really try and immobilize that as much as possible. Non-steroidals, orthotics, again, I'd go for that same orthotic that we mentioned before, which will offload that forefoot. And in later disease, obviously, local steroid injections and surgical techniques. Most of these in later disease are going to be an arthrodesis or an arthroplasty. So in recap, as I say, the subtle differences between these conditions is generally in the history, always compared to the contralateral. Assess that joint quality, and that will tell you a lot, about where it's at. Is it unstable? Is it arthritic? Imaging where you're unsure, and please feel free to be confident having a go with the orthotics, because I think that really will improve outcomes for your patients. And if you're ever unsure about anything or you just want to ask, get in contact with us by System 1 or email or give us a call. And thank you everybody for listening and inviting me along, and opportunity to ask any questions now if you like, or you can, if you don't want to, put them in the chat.
So first question in the chat, do podiatrists supply the cam boots?
We do, yes, yeah, we do. So we have a supply. We don't get through loads and loads, but we do have a supply if needed, yeah.
Cool, there you go. Do we get podiatry input for plantar fasciopathy?
So yeah, I mean, we spoke about this a little bit before, Desi, didn't we? So certainly we do. But I think in terms of MSK Podiatry, there's probably not a huge amount, many more things that we're going to do that you guys aren't already doing. So if, for example, you've got a really kind of heavily flat foot and you don't think off-the-shelf orthotics are going to sort of cut the mustard with that, then obviously you can refer to us and we can kind of have a look if we can provide them something better. In terms of steroid injections, we do offer them, not very commonly. Again, with these soft tissue ones, we've got a real risk of weakening that plantar fascia and also fat pad atrophy. So we're cautious, and they'd be kind of heavily advised to avoid any activities for the first couple of weeks following that. We do them, but only, I would say, where patients have had real significant longevity of symptoms, or they're in so much pain that they're unable to carry out any of their kind of normal activities. We may consider doing the injection and then putting them in a cam boot afterwards, as well. That's something we can try.
So just on that, so we did do the podiatry evidence base, which will be, if it's not already, on YouTube, and it was very much Matt put an input about exactly what he said and what the Nottinghamshire kind of pathways are. So it's just another reference.
Yeah, I could. Sorry, Desi, to cut in. I was just going to say I can share with you our internal pathway documents that we use for common conditions as well. I can send those on to you so you can kind of see what we're going to do when you refer them into us, and we can send those on. Would that be helpful? Yeah.
I'm sure that will always help us.
Yeah, sure.
So another question. I recently had a client who got rejected for orthotics from podiatry. The client also had sciatica symptoms, so the podiatry team said the pain is more concerned with the back and not the foot. I was wondering if there was anything you would want us to specifically mention while making the referral. Yeah,
so I sort of mentioned that we kind of no longer kind of accept just those referrals, but it seems to me like perhaps a bit of a breakdown in communication there. So if they've got foot symptoms as well, definitely we will see them. So I suppose when you're making the referral, just making that as clear as possible that that's the reason that you're kind of referring them to us. I mean, I can kind of look into that if at a later date somebody wants to give me the information. Yeah.
And just while people, if they're thinking of any more questions, so I put the self-referral link. So it could be that you put that in a preset text, but almost give guidance to patients of what to include, not just I have foot pain. So that's where you can help patients if they're going to do something themselves. That link is in the chat and will be sent out on the slides. And then, does podiatry offer cortisone injections?
We do, yeah. So we do mainly guided injections. We've got ultrasound, most of our main MSK locations. Only foot and ankle ones though, so you can't refer all your injections. So yeah, we do. Predominantly, most of them are going to be intra-articular injections, and as I mentioned, neuromas. They're probably the most common things we're injecting. Yeah.
The reason to ask if patients are adamant for an injection and podiatrist input for heel pain or fasciopathy is Podiatry Service better placed to offer holistic approaches?
So yeah, absolutely. So if the referral is simply for an injection, we're always going to see that patient. They're not going to be rejected, but we'd have that strong discussion with them about the kind of possible contraindications as we've just talked about there. And as I say, I would generally think about the kind of, the impact on their life, the longevity of the symptoms. What have they tried before? Have they really kind of significantly done everything we've asked them to do? Because if we don't inject at that point, what's their real other options is either to live with it or that they're referred on for surgical intervention. So I guess if you're kind of managing those risks, steroid injections are not as risky as surgery. But as we all know, in most cases, plantar fasciitis will resolve with a bit of time and a bit of intervention. But if that's not the case, then we may do some steroid injections at that point. Does that answer that question a little bit? So it's kind of not a never situation, but it's certainly not going to be your first line treatment. Yeah.
And now, grey area question: what about ankle ligaments? Is it MSK or is it yourself?
Yeah, so I think it's a combination. So I guess that would usually come probably to us via MSK. So you maybe refer to local MSK, and then if they thought we could deal with that or there's something we can do that might help in terms of their foot posture, generally speaking, probably it's going to come via that route most of the time. But it is a bit of a grey area. There's huge crossover between what we all do, isn't there? In truth, but again, we would accept that referral. Yeah.
Are podiatry accepting referrals for corns, callus, and warts?
So in an otherwise healthy patient, no. So in core podiatry, that they have much stricter access criteria, and sort of single lesions like that, painful or not, if the patient is not at risk, like a limb-threatening risk, they will be rejected. So if the patient was diabetic or had peripheral arterial disease, then they would be seen. So it's about managing risk of losing life and limb effectively in core podiatry.
A really common question, I'm sure. What is rough waiting times?
Yes, so at the moment, it does vary a little bit across the county, but probably around the sort of 6 to 10 week mark for MSK, and probably similar for core as well. Anyone that's kind of triaged straight into surgery, their waits are often a little bit quicker than ours actually for a first assessment, usually around about 3 or 4 weeks. But for surgery itself, I think it's around 4 to 6 months at the moment. It obviously varies all the time, but generally speaking, they're the numbers.
And what I learned recently is that you don't image, so that's where it's obviously what can we do, which are appropriate to help you in your referrals, but not that we over image as well. So there's just a recap of which images really make a difference to you and what are they.
Yeah. So with the plantar fasciitis, if you've got all the classic symptoms, so I tend to think of 3 things. Have they got any kind of neuropathic symptoms? If they had, I'm not thinking plantar fasciitis. Have they got pain first thing in the morning? that eases with a little bit of walking around. If they have, they probably have got plantar fasciitis. And is it directly painful on the plantar fascia enthesis with your palpation skills? I think if you can kind of say, tick those boxes, you can probably be 99% sure it is plantar fasciitis. So I wouldn't necessarily image that unless you were uncertain of a differential diagnosis. So if there was something that was kind of screaming out to you that this maybe not look like plantar fasciitis, for example, you thought maybe it might be a post tendon problem, then you could go with ultrasound with that to try and help you. Neuromas, if it's in that third space and they've got all those symptoms we talked about, again, I wouldn't necessarily image that. Joint problems, if we're going to be thinking about a local injection to a joint, we would definitely prefer to know what's going on in that joint prior to injecting. So if you're referring for that reason, an X-ray really would be helpful. In terms of X-rays, generally speaking, weight-bearing X-rays with a kind of DP and a lateral view are usually the best, because then we can get a better idea on deformities, as well as kind of the quality of the joint as well. Is that typically what you guys would do for a foot?
I believe so. If there's any differences, then please write in the chat. A question now. History of 1 year plus of plantar fasciitis. Ultrasound showed a 9mm thickened plantar fascia. It's had 4 injections in primary care and still struggling with pain, and he had a calcaneal spur on the X-ray too. Do you consider an ultrasound guide injection, or what are the other options?
I think I'm a cautious individual. I would probably think 4 injections is enough, whether they're blind or guided. And I'd be really concerned about injecting that any further. Other people may have a different view, but I would be thinking if that had been grumbling on for some time, if you're happy that it had all those kind of non-operative treatments, then I would probably be thinking of an orthopedic referral. So that they probably wouldn't want to see that in our podiatry surgery clinic, because, as I say, as a day case local anaesthetic, that's probably better in orthopedics. So if the patient was kind of willing, I'd probably be thinking an orthopedic referral. If they've not had all the other treatments, for example, they've not tried kind of a significant orthotic, or if you don't think they're doing their rehab, then obviously I'd push that a little bit more. But certainly we'd be happy to see that patient, but I probably wouldn't be thinking any further injections.
Thank you. So if there's no more questions, I just want to say thank you very much for your time. I really appreciate it. We've got one more question. I'll keep talking. Just so you know, I said you'll get your slides. It's roughly about 4 weeks turnaround for these videos, but we've got Christmas coming up, but we will send it out. I'll send an email in the new year, but I've sent you the link where they all go anyway. Our last talk of this year is about the evidence on sciatica or radicular pain, and then we've got the neurospinal assessment unit joining in as well. So we're having a look at that primary care aspect, but touching on when we refer to spinal unit, just so that everyone's aware. Any comments, questions, or anything for the new year, please just email me. Laura has gone off on maternity leave, so it's just me now. So any questions, please direct them my way. Now back to podiatry. Could you tell what management options can be offered for calcaneal spurs?
So is that a plantar calcaneal spur?
Yes.
I mean, most of the time we tend to think of a plantar calcaneal spur as a sort of incidental finding. But having said that, I think that's kind of our standard approach, and I think most of the time we're thinking the plantar heel pain is more soft tissue. So that most commonly is plantar fascia, but could be the fat pad that's causing pain, could be a subcalcaneal bursitis, but mostly we're thinking soft tissue problem. But I will say, on a handful of occasions, I have known patients who their pain isn't resolving, and we can see on X-ray or ultrasound that they've got a significant calcaneal spur, and they've gone to surgery and they've had that spur removed, and they do quite well following it. So I don't think it's entirely always to be ignored, but if it's a small spur, it's probably unlikely to be causing a problem. If it's a larger spur and maybe you can even kind of palpate it, then maybe it is an issue. In older patients, that kind of atrophy, that wearing away of the fat pad, is really common. So if you sort of touch the heel bone, there's sort of nothing on between skin and bone really, and so sometimes they just need a little bit of replacement cushioning. So a really cushioned sort of orthotic can be really helpful for those. But yeah, there are definitely on occasions where the spur may be an issue. Yeah.
Brilliant. We will close it there with no more questions, but thank you, Matt. This has been invaluable to hear from you and everything that you do in your service. Thank you and I'm sure you're going to have lots of thanks now in the chat.